17% of patients with recurrent pregnancy loss are having uterine anomalies, while 7.3% of infertile are having uterine and Mullerian anomalies, congenital anomalies of the uterus, while 6.7% in general population. So this telling us again it's far common in patients with recurrent pregnancy loss, but it's leading to second trimester abortions. And also it leads fetal malpresentations like breech presentation or other types of malpresentation and preterm labor. Immunologic factors, around 15% of patients with recurrent pregnancy loss are having immunological abnormalities. And the commonest immunological abnormality is autoimmune factors, especially antiphospholipid antibody syndrome, which accounts around 5 to 15% of women with recurrent pregnancy loss are having this syndrome or this abnormality. And this antiphospholipid antibody syndrome, it leads recurrent miscarriage, especially after 10 weeks of pregnancy. It also leads preterm delivery, fetal death, early onset preeclampsia, and fetal growth restriction, or everything related to placental insufficiency or placental dysfunction is related to antiphospholipid antibody syndrome. To diagnose antiphospholipid antibody syndrome, we have clinical criteria to diagnose antiphospholipid antibody syndrome. The first part of the criteria is obstetric criteria, vascular and clinical criteria. Obstetric criteria is these three things: to have more than one unexplained morphological normal fetus loss, more than 10 weeks of gestation, or severe preeclampsia or placental insufficiency is stated the delivery of a baby before 34 weeks, or more than three or more unexplained abortions before 10 weeks. Vascular criteria is more than one episode of arterial, venous, or small vessel thrombosis in any tissue or organ, while laboratory criteria is presence of anti-lupus anticoagulant or anti-cardiolipidine antibodies or anti-P2 glycoprotein 1, immunoglobulin G or M antibodies of this glycoprotein. And to diagnose, you need to have at least one clinical and one laboratory criteria, and they must, especially the laboratory criteria should be there more than 2 occasions, at least 12 weeks apart. So when you do the investigation, if it's positive, you need to repeat it after 3 months so that you can diagnose the patient as having antiphospholipid antibody syndrome. Other things which can lead to recurrent pregnancy loss include endocrine factors. Around 8 to 12% of patients with recurrent miscarriage have endocrine disorders, which include thyroid disorder, hyperprolactinemia, diabetes mellitus, or polycystic ovarian syndrome. Luteal phase defect. Luteal phase defect is also another cause of recurrent pregnancy loss, especially early loss, and it's attributed mostly due to folliculogenesis, abnormalities in folliculogenesis, which is the subsequent abnormal luteal function, and there is dysynchronization of the endometrium with the corpus luteum. For example, the endometrium age will be around 2 days behind, or 2 days, it may lag 2 days from the expected cycle age. So this leads, for example, when there is implantation, the implantation to happen, it needs synchronization between the implantation and the age of the time that the endometrial receptivity and the fertilized ovum. So this receptivity will not be there if there is luteal phase defect. And the treatment options will be mostly to support the luteal phase with progesterone, but it's not proving that it works for every patient. Thyroid disorder, generally, if the patient have thyroid disorder, it should be treated in patients with recurrent pregnancy loss or not. Thrombophilia, it's coagulation cascade abnormalities or mutations like factor V Leiden deficiency, prothrombin disorders, or antithrombin and protein C or S deficiencies or gene mutations. These things are not clearly related to recurrent pregnancy loss, and the patient will need to be investigated according to that thrombophilias. To evaluate a patient with recurrent pregnancy loss, we need to take history, detailed history and physical examination. And you should make sure that the pregnancy is documented biochemically, histologically, or with ultrasound. Because some patients may tell you that she was pregnant and she ended up abortion, but she haven't done pregnancy test. Ultrasound was not done, and there is no histological evidence available. So you should not take just the words of the patient, how she knows that she was pregnant. You should ask the patient. She should bring the pregnancy test result which was positive, which ended up with abortion. Because some patients, especially our setup, will tell you that she's having 10 abortions in first month, within 2 years or within 1 year. So you should ask the patient, she need to bring the evidence that there was pregnancy, be it HCG positive or histologically it will not be available in the country because we are not doing histological investigation, but there you can also ask the patient to bring ultrasound scans which was done before the abortion. You do physical examination, general physical examination, most importantly the weight of the patient, and you should calculate the body mass index, and pelvic examination is also important. Then the investigations which are possible for recurrent pregnancy loss in Somaliland that we have genetic, we can't do the genetic analysis in the country or karyotype. If it's necessary, when you have done all the other things, you can send the sample outside abroad. Anatomical abnormalities, for example, to see uterine to investigate whether the uterus have anatomical abnormality, whether acquired or congenital. You can use transvaginal sonography and ultrasound, which is available, which can tell you the masses, is there any mass or anything or other things inside the uterus. You can also use saline effusion sonography, which is more telling you about the inside the cavity of the uterus. Hysterosalpingography, especially these two are also very important for cavitary evaluation, intracavitary evaluations, and they are available in the country. An MRI, especially for those congenital abnormalities, if you suspect, especially to classify the congenital Mullerian anomalies, you may require MRI to see the outside shape of the uterus. And the treatment options will be surgical correction of this abnormality. The other thing is immunological. Immunologically, to send anticoagulant or anticardiolipidine antibodies or TP2 glycoprotein 1 antibody. All these three are not available, but they can be sent through some laboratories to outside the country. So you should consider, especially send these three things. If it's costly, you can send or three of them. It's better to evaluate and send three of them to that laboratories who can send the sample outside the country. For endocrine evaluation, you will do the thyroid function test and prolactin, fasting blood sugar for diabetes, and you will treat accordingly if there's any abnormality. Day 3 FSH, you should do day 3. The third day of the cycle, you can do follicle stimulating hormone, especially those patients in old age, because of the old age, premenopause and near to the menopause, the FSH is high rated and they are highly likely to have recurrent pregnancy loss. The other thing is mid-luteal phase progesterone, which can tell you the luteal phase defect, but it's not diagnostic, but it may tell you some clue, something that there is the progesterone inadequacy. So you may support that patient with progesterone. It's common practice in the country. The other thing is if the patient is using tobacco or cocaine, they should discontinue because two of them are linked to the pregnancy loss. Obesity, which is very common in the country, high prevalent in the country, the patient should lose weight. And weight loss is very important in studying management of recurrent pregnancy loss. The lastly, which is very common in the country, is chat. And chewing chat is not common for the female, but if it's there, you can try discontinuation may help, even though we don't have proof evidence and it needs research, but we can add as this substance olive and we can take the opportunity to encourage the patient to discontinue this habit. Other things which is commonly used in the country, you will see every patient who have recurrent pregnancy loss who goes to any hospital in the country, they will send all these investigations which have no value for the patient management. It's okay to send CBC and urine analysis as a routine liver function and renal function test if you suspect something, or the patient is hypertensive or diabetic and trying to conceive, you can send these two. Otherwise, all the rest are not SOFI are not indicated to do for patients with recurrent pregnancy loss, especially early pregnancy loss. Hysteroscopy is not available in the country. I think it's only possible to get hysteroscopy in one hospital or 2 sites. So if it's required, especially intracavitary lesions and also for management, we can send. But the most important message is you should give the patient psychological support and tell her that she will get pregnant, she will get successful pregnancy, or the chance of getting successful pregnancy is high even after 5 abortions. The other message is if you can't do all these investigations, you should send the patient in some other hospitals or other doctors who can do these investigations. Intaas kun kusoo koobinaa. Thank you.